Good morning, everybody. We're glad you're here. Happy Friday. I'd like to welcome Eric and Julie. They're our geriatric medicine fellows. They're actually engaged to each other. Welcome, and what a cool fact about you. They're both from Canada. They met in medical school. They completed their internal medicine residency at the Christ Hospital in Cincinnati before coming to Advocate Aurora for their geriatric fellowship. Following fellowship, they're planning on moving upstate New York with their dog, Diana. I'd like to give the floor to Eric and Julie. Welcome and thank you.
Thank you so much. So we will be presenting a dementia overview. We have an interest in primary care, so this will be geared a little bit towards that setting, and it was designed with that in mind, but it should still be hopefully helpful and relevant for those of you who work in the hospital setting as well. We don't have any financial disclosures to make. And well, thank you for that introduction. I don't have too much to add. I just wanted to put our emails on there. If anyone has any questions afterwards, feel free to send us emails. eric.tharmatherai@aah.org or julie.vanbardwick@aah.org. That picture of us was taken shortly after we got engaged in Barcelona.
So we wanted to go over a few objectives. Julie, would you like to say the objective?
Sure, yeah. So we wanted to describe the differences between mild cognitive impairment and dementia, how to work up older adults with cognitive complaints in the primary care setting. We'll differentiate between some classical clinical presentations of the most common dementia syndromes in older adults. We'll briefly cover when to prescribe and deprescribe some common medications. And we will touch on a couple of the new exciting medications seen in, for Alzheimer's.
All right, so going through some definitions. So the first off is we have mild cognitive impairment. This is an intermediate clinical state between normal cognition and dementia. So there's two forms. So there's the amnestic form, which is impaired memory function, and it doesn't really interfere with their daily function or independence. This type of mild cognitive impairment, or MCI, usually progresses to Alzheimer's dementia. The next form is the non-amnestic form. So this is an isolated impairment in a single non-memory cognitive domain, such as executive functioning, language, or visuospatial skills. This specific MCI may or may not progress to other dementia syndromes, such as frontotemporal dementia, vascular Lewy body, etc. Next is the definition for dementia, or also known as major neurocognitive disorder. So this is one of several conditions characterized by a decline in cognition involving one or more cognitive domains severe enough to interfere with your daily function and independence. So really affecting those activities of daily living or independent activities of daily living. There is a DSM-5 criteria for dementia, and it is as follows. So there's evidence from the history and clinical assessment that indicates significant cognitive impairment in at least one of the following cognitive domains. So learning and memory, language, executive function, complex attention, perceptual motor function, and social cognition. The impairment must be acquired and represent a significant decline from a previous level of functioning, so affecting those ADLs and IDLs. The cognitive deficits must interfere with independence, and the disturbances are not occurring exclusively during the course of delirium.
So we thought we would just quickly mention a few of the screening tests that we use, or that are commonly used. So the mini-cog, the Mocha is one that I think most people are very familiar with, the Montreal Cognitive Assessment. The St. Louis University Mental Status Exam, or SLUMS, is becoming more common. The Cochrane isn't being used widely at this time, but is a pretty new screening test out of Mayo Clinic. The Mini Mental Status Exam, or MMSE, is very common, and the Functional Activities Questionnaire. There are a lot of other tests as well, but these are some of the most common. This is a few of the tests that you might see. We just thought we'd put them up on the screen for you. So the mini-cog, including the clock drawing, Mocha, and the SLUMS. So the mini-cog has about a 91% sensitivity for dementia and 86% specificity. The problem with this, this is really not good for identifying MCI. It's just good for dementia. The Mocha, I think, is a much better test for identifying mild cognitive impairment. For the Mocha, you have a score out of 30, 26 or above is normal, and 25 or less is abnormal. It has, as I mentioned, a much better rate of detecting MCI. It's about 89% sensitive for MCI, and it has about a 91% sensitivity for dementia. It's available in over 60 languages and dialects. There's also a version for the blind, where they basically take out the visual spatial portions. And this is what our speech and language pathologists typically do if you order a cognitive screening test in the inpatient setting at Advocate Aurora. The slums examination is also very good for identifying MCI and dementia. It's not quite as good as for MCI as Mocha. The rate of sensitivity is anywhere between 67 and 87%. And then it's somewhere between 84% to 100% in sensitive for dementia. The MMSE is pretty good. However, it's copyrighted, so it's being used a little bit less than some of these other tests, which aren't copyrighted. And then the Cochrane, which I mentioned, is being used at Mayo Clinic, and they say that it's about 92% sensitive and 91% specific for dementia. Once you have a patient with some noted abnormalities, either on screening tests or functioning, common workup includes some labs like checking their vitamin B12 levels, their CBC, checking their thyroid function. You should also do depression screening. Patients with depression can appear very similar to those with dementia. The older term is pseudo-dementia, where it's just really uncontrolled depression. And once you treat their depression, their cognitive complaints can really improve significantly. Additional testing really depends on the patient history. So, for example, we may check for neurosyphilis in patients with concerning history, or in areas where there's a high syphilis rate. For example, Eric and I trained in Cincinnati, which had a surprisingly high syphilis transmission rate. So it was something that we tested for frequently. For patients with a long alcohol use, you may check folate or calcium for patients with myelodysplastic syndrome. There's not really any clear data on routine testing for things like electrolytes or liver panel. So that's really at your own discretion. And then imaging is also a little bit controversial. So it tends to be most specific in situations of young age, like less than 65, a pretty sudden course, those with a clinical picture suggesting NPH, CVA, brain mets, head trauma. The American Association of Neurology recommends 4 routine neuroimaging in patients with dementia, whereas the American Geriatric Society actually recommends against it. So it's not entirely clear what you should be doing. I think it's really up to the provider to make that decision. If you are getting neuroimaging, an MRI is much more helpful than a CT scan.
So now we're going to talk about some quick hits for some common dementia syndromes. We're going to just go over 5 that you'll commonly see in the primary care setting. Each one could definitely have its own lecture, so we're going to try to do all that in a few minutes. So starting off, I just want to go over which diseases are like the top 3 that you should definitely know because they're the most common. So as we all know, or as we all can guess, that Alzheimer's dementia is the most common type of dementia that we'll see in our practice. The second most common originally was thought to be vascular dementia. However, with increasing diagnostic awareness, the second most common is actually Lewy body dementia. And then the third most common is going to be vascular dementia. So going over, starting with Alzheimer's, usually the onset, it's gradual. You get primarily memory loss. So memory loss, usually delayed recall first and then short-term recall. The domains affected are memory, language, visuospatial, and you rarely get motor symptoms. However, you can develop apraxia later. The progression is typically longer, over 8 to 10 years, and the neuropath you'll see is cortical atrophy, hippocampal atrophy, and some tau protein deposits. The best treatment of choice with the most data is the acetylcholinesterase inhibitors. We usually, this chart says mild to severe, but we usually started off for mild to moderate dementia, and then memantine for moderate to severe dementias. The next one's vascular. So this may be sudden or stepwise in onset. So you have normal level of functioning, you get ischemic or a vascular lesion, that plateaus off, and then you get another decline again. So the cognitive domains and motor symptoms all depend on the location of ischemia. So for example, I had a patient who he had an ischemic lesion in his basal ganglia, so he presented with a Parkinson-like picture. The progression is usually gradual stepwise, like I said earlier, and the neuropath you'll see is either ischemic, hemorrhagic, or hypoxic lesions. In terms of medication treatments, there aren't really much. Usually you just do vascular risk reduction. However, you can consider acetylcholinesterase inhibitors for those with memory deficits, but the level of evidence isn't as high as for Alzheimer's.
So I'll cover the next few. Lewy body dementia and Parkinson's disease dementia, I think, are kind of two ends of the same spectrum of the disease. So with Lewy body dementia, you typically present with your cognitive changes first and motor symptoms later. So cognitive symptoms, apart from memory loss, can include visual hallucinations, REM sleep behaviors such as acting out dreams, whereas the Parkinson's or motor symptoms develop much later. Parkinson's features can be things like bradykinesia and tremor, and shuffling gait, things of that nature. Lewy body dementia tends to progress a little bit faster than Alzheimer's disease. And then neuropathology is the Lewy bodies as in the name. And then you can see some global atrophy. Parkinson's disease dementia, on the other hand, you develop those Parkinsonian features earlier on, the tremor, bradykinesia, et cetera. And then typically you have a number of years before you develop more of the cognitive issues, memory, hallucinations, et cetera. For both of those, the movement part of the disease can be treated with carbidopa-levodopa, but that really doesn't help with any of the cognitive changes. We do use acetylcholinesterase inhibitors for the cognitive or for the memory complaints, at least for these types of dementia as well. Frontotemporal dementia is a little bit different than the other ones. It tends to present in an earlier age, often under the age of 60. This one has just been in the news. Bruce Willis just announced that he was diagnosed with this. Cognitive domains typically include executive disinhibition, like inappropriate behavior. Apathy is very common. And then language and aphasia is often affected as well. There's different subtypes of frontotemporal dementia. Primary progressive aphasia is kind of on the spectrum, where patients tend to or develop the inability to speak over time. The neuropathology of this one is atrophy in the frontal and temporal lobes. Unfortunately, we really don't have any treatment for the cognitive issues in frontotemporal dementia, at least for the memory issues. We try and treat some of the depressive symptoms or apathy with SSRIs, but it does not help with memory. We do just want to mention a couple other types of dementia. So NPH or normal pressure hydrocephalus, it can be seen that has a classic triad of gait impairment, urinary incontinence, and dementia, where typically the memory issues develop later than the gait impairment and urinary incontinence. And then there are rapidly progressive dementias. Those can sometimes present in very young ages. They start very suddenly, and those require a lot more evaluation. You do have to be concerned for things like Creutzfeldt-Jakob disease or mad cow disease. That's pretty rare, but I know that Zilber Hospice has seen a couple cases in the last few years. We did want to show the FAST scale. This is for Alzheimer's specifically, but it's the progression of dementia, starting at 1, normal aging, and then patients typically progress through the stages down to 7F, the most severe. Not everyone progresses in the exact same way, so people may skip steps. So they may have urinary incontinence before they really need help putting on clothes, but it still helps us give family and patients a way to understand how things may change over time. It's also important to note for palliative care, patients, I believe, need to be stage 7 before they can are really hospice appropriate. We will talk about the medications, but I think non-pharmacological management is at least as important, if not more important, than some of the medications for Alzheimer's. So making sure patients are getting physical activity if they're able to, controlling their comorbidities, especially for things like vascular dementia, making sure their blood pressure and diabetes are under control. Emotion-oriented psychotherapy is helpful not only for patients, but also for families and caregivers. We really need to be assessing caregiver fatigue and strain. There are many resources that can help them. There's adult daycares, there's respite cares, there's help groups, things like that. We should be encouraging family to help patient do activities that they previously enjoyed. Home OT evaluations can help us assess safety and help modify the patient's environment for their current needs. And that might be something that's done multiple times through the course of their disease. As they continue to progress, they may have a change in their needs. Safety screening, that's a little bit of a broad topic, but making sure that a patient's safe if they're living alone or if they're living at a home with others, assessing if there's firearms in the house or if the stove is connected and they're at risk of starting a fire. Are they at risk of wandering? Are they a fall risk? All of those need to be considered. And then driving evaluations. So patients sometimes drive beyond when we think it's safe, and it is sometimes our duty to evaluate patients and unfortunately sometimes take away their licenses. Luckily, we do have OT evaluations that can be done to really assess if patients are safe to drive, if they have the cognitive reserve to actually drive safely. So that can, if you're not sure, you can always refer to OT.
Rehab.
Rehab, yeah.
All right, now time for drugs. So as physicians, we are able to prescribe some medications, and a lot of families will come to you to ask what can be done for their loved one. So going over the treatment options, so we'll mostly be talking about treatment options for Alzheimer's dementia. However, we'll state when we can use these medications for other indications as well. So the first one is the acetylcholinesterase inhibitors. So these are medications like donepezil, galantamine, and rivastigmine. From its name, so it inhibits acetylcholinesterase. So it essentially inhibits the breakdown of acetylcholine in the synaptic cleft. What's important to note is that this helps treat symptoms and improve global functioning. However, it's really important to stress to the family that this medication does not cure disease. It merely slows the rate of decline that you'll see in a patient. We mostly prescribe this medications to patients with Alzheimer's with mild to moderate dementia, as well as Lewy body dementia. There is some data to show that it is helpful in vascular dementia. However, only if they have those memory impairments. And then lastly, it's not helpful for frontotemporal dementia, and it can actually worsen symptoms. So being really sure making sure that you rule out frontotemporal dementia before starting these medications. These medications can have pretty distressing side effects, so it's really important to continuously reevaluate the utility of these medications. So side effects include nausea, vomiting, diarrhea, loss of appetite, weight loss, bradycardia, hypotension, and they can also cause sleep disturbances, so causing vivid dreams or nightmares, and this is especially worked with donepezil. So it's really important to reevaluate the utility. And if the patient doesn't have any response when you initiate the medication within 3 to 6 months, then it's important to discontinue the medication. The next medication we're going to talk about is memantine. How this works, I guess first I'll talk about how the brain works and how the diseases progress. So usually you have ischemia in the brain, and then you get excitotoxicity of the NMDA receptors in your hippocampus. And this causes lots of glutamate flooding into your synapses. So this continuous activation and overactivation and all this glutamate flooding your system actually causes neurotoxicity in your brain. So NMDA blocks the receptors and is neuroprotective and stops this process from happening. Usually we prescribe this medication for patients with moderate to severe Alzheimer's dementia. And again, it might be beneficial in vascular dementia only if they have that amnestic memory impairment.
So we just wanted to touch on a couple of the new monoclonals that are out there. They have been in the press a little bit, and you may have patients that are interested or asking questions about this. So aducanumab and lecanemab are the names of them. The mechanism for both is reducing brain amyloid plaque. The population that it's designed for or approved for is the same. It's only for mild Alzheimer's or mild cognitive impairment with proven plaque burden. So they have to have either a PET scan or an LP with beta amyloid. So it's not kind of a presumptive diagnosis. It has to be very, very certain. The data for both of these is a little bit different. So aducanumab was first approved in 2021 by the FDA. It has been shown to reduce brain amyloid plaque. However, there hasn't really been any meaningful patient benefit shown based on this. It's kind of a proxy marker that we think will help symptoms, but none of that's actually been proven. Because of that, and because of the uncertain patient benefit, its approval was met with a lot of controversy. The FDA actually ignored the recommendations of its own advisory committee when it approved it. Multiple committee members ended up resigning in protest. And without the meaningful patient benefit demonstrated at this time, multiple physician groups have recommended against prescribing it, including the American Association of Family Physicians. Lecanemab, on the other hand, is even newer. It was approved by accelerated approval by the FDA last month, January 6th of 2023. We expect the FDA to decide on full approval in the next 4 to 8 months. This medication has been shown to have some cognitive benefit. It's fairly small, and it's only been shown at 12 months. We really don't have any longer term studies. And we're not expecting any sort of cure or reversal of Alzheimer's, just a small increase in cognition or improvement in cognition, sorry. Because it's not fully approved at this time, Medicare is not covering it. The predicted cost is around $26,000 a year. And that doesn't include additional clinic visits or MRI scans. For both of these medications, there are some pretty alarming side effects or risks. Risks include brain hemorrhage and brain edema for both of these medications, to the extent that you actually have to do regular MRI screening for both. They're both infusions that are given, I think, approximately every 4 weeks. And after, I think, every couple infusions, you actually need to do an MRI scan to check for brain swelling and hemorrhage. So because of these pretty uncertain benefits at this time, very narrow patient population, and costs and things like that, we really aren't recommending this. I think we need a lot more data before we feel comfortable recommending these medications. I think a lot more studies have to be performed.
Yeah. And we just wanted to let you know, because Julie actually had a patient, was it last week?
Yeah, coming in who specifically was interested in some of these medications, but Not only are we not actually even able to give these medications yet, because Advocate Aurora's pharmacy committee hasn't assessed them or hasn't assessed lecanemab at this time. But just the risks involved and the very narrow patient population. And like, I think the patient who came to see me had moderate Alzheimer's, so she would not qualify. They're just not something that we really feel comfortable recommending at this time.
So that was our presentation. Thanks for staying awake. We can only see Rachel Gage right now, so she's been awake the whole time. So we just have some key take-home points. So we wanted you to understand the difference between mild cognitive impairment and dementia, so really affecting those IADLs and ADLs with dementia. We wanted to go over some different screening tests and really tell you why Mocha is the best test, because that's the one that we love the most. History is very key when trying to differentiate between the different dementias. There's a lot of treatment options, so remembering those non-pharmacological methods, the ACE inhibitors, and memantine for Alzheimer's dementia. And lastly, with the new medications, the evidence isn't really there, so we'll see what's to come with those.
Yep. Thank you.
Well, thank you, Julie and Eric. That was excellent. We really appreciate this updated information. There's a couple questions in the chat. So one was from me, and I wanted to know more about emotion-oriented psychotherapy. Where do we find a psychotherapist who has this? Is it a credential or a certification? Because I would love to recommend that to patients I see.
Yeah, I think a lot of therapists in general can provide that. I'm not sure about specific psychotherapy. I believe at Sinai on our 4th floor of the OHC, they have some great therapists that we can we send people to. I think when we send them, we both have to place a service to behavioral health, and then we also have to actually provide the number because the patient has to call themselves or their family has to call. I don't know about specific credentialing, but if you place an order and specify emotion-oriented psychotherapy, I think a lot of therapists should be able to help you. Or if they can't do so, hopefully they can send you to someone or recommend someone who can.
We did it a lot more in Cincinnati than we do here. All right.
And Dr. Rommelfinger says, thanks for the presentation about the FAST scale. Could you please remind us how to correctly score a patient? For example, a patient no longer walks, but no significant aphasia. How then do we score if they're skipping over some of those stepwise motions in the actual FAST scale? And then his second part of the question is it appropriate to use FAST for non-Alzheimer's dementia?
So for the FAST scale, I believe you use the lowest point that they've achieved, unless you think that it's from a different cause. For example, if they have urinary incontinence, but it's you think it's unrelated to their dementia, like they had long-standing urinary incontinence prior to dementia. I believe that's how you scale it. And then we sometimes talk about FAST scale for non-Alzheimer's dementia, but we don't really use it like, I guess, in our notes or something. We kind of mention it when we're talking to each other, like they're similar to this stage of Alzheimer's, but it's not entirely appropriate to use it because
It was only intended.
Yeah, it was only really designed for Alzheimer's, and some of the dementias progress in different ways. For example, the vascular can be more of a stepwise, and depending on where their lesions are, they may have different deficits at different times. Hopefully that's helpful.
Yeah, that's helpful. Richard says, doesn't Mocha require registration and competency training?
You are supposed to have a clinician. I believe you can still perform it if there's someone in your practice or something who's certified. I'll be honest, Eric has done the training and I have not. There are a lot of specific rules regarding how to say certain things, how to present different questions to the patients, making sure you're not repeating the same thing too many times, making sure that you're scoring things appropriately. So even if you don't do the training, I think it's still good if you have read there. You can even just find a PDF, I believe, online if you look it up, that kind of goes through a lot of the points quickly for you so that you really understand how to administer it correctly. But it sure is
Yeah,
great to, and I've kind of relied on Eric for his guidance on some of that. Because it is a little bit,
nuance.
yeah, there is a bit more nuance than just saying what's on the sheet.
But yeah, the actual I guess the standard is that as long as someone else is trained, you don't have to be trained.
Yeah, that
Or you're
someone that you're practicing with or under.
But the training itself only takes an hour, and it's free for I think
Mhm.
all physician and nurses and students.
Yeah.
Right now.
Excellent.
And
Well,
you are
Mark, that he says the training, and it is worthwhile. So anyone listening who is interested can Google Mocha and take the official training. I had another sort of thought pop into my head. We do have more increased diagnostic awareness that more adults are being diagnosed with like autism and ADHD. Is the Mocha or other screening tests, are they sort of adaptable or adjusting for people who have pre-existing executive challenges, executive function type challenges?
No, I think that's very much based on your clinical judgment. As well as, so patients with pre-existing executive dysfunction is one part of it. Patients with very, very low education, it may not be very helpful for. You are supposed to add another point if someone has less than 12 years of education. But I mean, I've seen patients who are not able to read and write. And for those patients, it's really not helpful. And honestly, none of the screening tests are very helpful for patients like that. You really have to rely on history from the patient and family and caregivers to know how things have changed, because they can't perform a lot of the tasks that are needed, not only in the Mocha, but in a lot of the other screening tests.
Mhm.
So Jennifer adds that cognitive behavioral therapy would be best for people with dementia, bringing them to the here and now, looking for ways to improve their current situation. She mentions she used to work with dementia patients and it gets difficult as they progress, but she did various therapies with them. And for her, she does have some extra training and working with geriatric
Okay.
patients. So
Oh, nice.
maybe that right therapist might be the best fit.
Absolutely.
And another thing we want to add, so Julie and I are practicing in a place with not a lot of resources next year. So we're trying to build up our toolkit. And one thing we like to give to a lot of the families for caregivers, it's a YouTube link. It's the UCLA caregiver videos. So these are just UCLA released a bunch of caregiver videos on how to take care of a patient with dementia at home. So like responding appropriately to their agitation or aggression, and how to ask them to do multi-step commands, or even not even doing multi-step commands, just breaking everything down to simple one-step tasks, especially with those with advanced dementia. So that's another thing that we recommend highly.
And then also, as we're talking about resources, the Alzheimer's Association website, www.alz.org, is very helpful. They have local chapters, and there's lots of resources associated with that.
And I think they can provide like a medical bracelet to patients with Alzheimer's dementia. So we just had a patient we saw on home visit. We recommended that because he had trouble with wandering. And so they'll provide a medical bracelet so that if he is found like far away, it says like, I have dementia, and then a number that you can call.
That's great. Paige asks if you've had patients that have had a neuropsych evaluation for cognition prior to your appointments. She mentions when she did her Jerry fellowship, some of the patients had a neuropsych eval prior to being seen in the dementia clinic at the VA, but other patients only had a memory screen.
Yeah, so we see kind of a combination of both. So we have luckily a neuropsychologist who comes to our clinic a couple of days a week, Dr. Franchow. She's fantastic. Some patients have already seen neuropsych. Some patients have just had a memory screen. Some people haven't even had that, and they just have kind of just memory complaints. So kind of the whole spectrum of people, or whole spectrum of evaluation levels that have come to our clinic. It's certainly helpful to already have a neuro psych evaluation, but if we think it's appropriate and they haven't had it, then we'll happily refer them, and they can usually get that done before the next time they see us.
Sometimes we'll schedule the neuropsych eval like right before our appointment, so they'll have the eval then and there, and then we can talk about the results right afterwards.
Yeah, so we can talk with Dr. Franchow about her evaluation, for example. And sometimes in that time period between when we first see them and when we get a neuropsych, we can, if we think it's appropriate, we might get imaging, we'll get labs. And ask family to try and keep an eye on certain symptoms and write down how often they're seeing issues with certain behaviors, for example. So we still try and get some things done in between.
I utilize that too. I ask my families to journal a lot, like keep track of this and keep track of that. Another thing I saw when I was living in Chicago, someone did a presentation on how to use improv to help with their dementia patients. I guess it was
That's
some
awesome.
occupational therapist, and they sort of go, because the one rule of improv is always say yes. You never say, go forward with yes.
Yeah.
And since I have a background in the arts and theater, I use this a lot when I was a CNA, started as a CNA, and always saying yes to my dementia patients. Yes, and sort of with a toddler has always been very helpful.
Yeah, that's great.
Well, any last questions? We're going to wrap up. Thank you all for being here. Happy snowy Friday morning. And again, thanks to Julie and Eric. We appreciate your time and your expertise.
Great,
Thank you very much.
Have a terrific day, everyone. Bye.
You too.